Hello, everyone. We're going to be talking about dysrhythmias today. This is a good review or refresher of some of the common dysrhythmias that we deal with. A lot of this we already know, but some of it was at least new to me. The first part we're going to talk about is reentrant tachycardias and wide complex tachycardias. The next part is going to be an update on rapid A.FIB, A-Flutter guidelines. And the last thing are ECG changes that you look for in syncope. Now, the first part is a good refresher review. We already know about reentrant tachycardias. So when we're dealing with AVRTs, you have either orthodromic conduction through the regular AV node and then antidromic retrograde conduction through the accessory pathway. So you have forward flow through the regular AV node and backwards flow through the accessory pathway. This leads to narrow complex tachycardias. And antidromic AVRT is when you have forward flow through the accessory pathway and retrograde flow through the regular AV node pathway. And this leads to wide complex tachycardias. Antidromic AVRT versus VTAC, it's very difficult to differentiate in clinical practice. There are ECG criteria that you can use, but honestly, we should always treat these as being VTAC because it's very difficult to differentiate the antidromic conduction, which through the accessory pathway, which leads to this wide complex tachycardia from VTAC. And so we should treat these all as VTAC. Now, the narrow conduction pathway of orthodromic AVRT, which is forward flow through the regular pathway and then backwards flow through the conduction through the accessory pathway, is difficult to differentiate, but it's also not important to differentiate from AVNRT. AVNRT is where you have circular flow within the AV node, so you have a reentrant tachycardia within the AV node itself, as opposed to an accessory pathway that's separate from the AV node in orthodromic AVRT. So AVNRT versus orthodromic AVRT, either way, they're narrow complex tachycardias you treat as SVT, and you give them an AV nodal blocker. By giving them an AV nodal blocker, you're slowing down conduction through the AV node, and they'll convert back into sinus rhythm. Now, once they've converted to sinus rhythm, you can see if you have signs of an accessory pathway. In this case, you have signs of a delta wave and narrow PR interval. So you can say that this patient has WPW. So therefore, you know that the patient had orthodromic AVRT as opposed to AVNRT. Regardless, though, it's an academic exercise. The treatment is just an AV nodal blocker. So in summary, if you have a regular narrow complex tachycardia that's not sinus rhythm, you're going to treat it as SVT. It's either orthodromic AVRT or AVNRT. You're going to give them an AV nodal blocker like adenosine, amiodarone, beta blockers, calcium channel blockers, or digoxin. If you have an irregular narrow complex tachycardia, you're going to treat it as rapid A.FIB Flutter, which we're going to talk about next in this presentation. If you have a regular wide complex tachycardia, it's either antidromic AVRT or VTAC, but in all of these cases, we recommend that you always just treat it as if you have VTAC. So if they're stable, you give them procainamide. If they're unstable, you give them electrical cardioversion. And if they're in irregular wide complex tachycardia, then they're either in VFib, so you're doing ACLS defibrillation, or they have antidromic AVRT with rapid A.FIB Flutter, meaning, so if you have a patient with WPW and A.FIB, you're going to cardiovert them. You should never give these patients an AV nodal blocker, because if you give a patient an A.FIB with WPW and an AV nodal blocker, then you're going to have increased conduction through the accessory pathway. So anyone who has got antidromic AVRT, if you give them an AV nodal blocker, you're going to increase the conduction through the accessory pathway. You're going to make their tachycardia worse, and then it'll probably degrade into VFib. So they're going to arrest. So you must never give these patients an AV nodal blocker. It's best to always stick to cardioversion. Now, differentiating primary versus secondary wide complex tachycardias. If you have a primary tachycardia, it can either be atrial in nature with a conduction system disease, or it can be a malignant ventricular dysrhythmias, which leads to cardiac arrest. So the treatment is just ACLS guidelines. But if you have a secondary wide complex tachycardia, it's where your wide complex tachycardia is due to some other systemic illness. So if you have a toxic ingestion of sodium channel blockers like TCA overdose, cocaine, etc., or if you have a metabolic reason to be in wide complex tachycardia like hyperkalemia, or if you have ischemic reasons to like an ACS event, then the treatment needs to be focused on the underlying cause as well as following your ACLS guidelines. But it's important to not overtreat secondary dysrhythmias, where the dysrhythmia is secondary to some underlying cause. Linton et al. And Schuster et al. Both did studies that showed that a major pitfall in emergency medicine is that we have a drive to overtreat. It's important to not worry about focusing on the heart rate specifically if that is if it's compensatory. You should focus on the underlying disease that's triggering this dysrhythmia. So if they're septic, giving them a beta blocker is harmful. It's going to reduce their cardiac output. If the patient is a PE, fluid bolusing them can be harmful because you're going to reduce their cardiac output. Unless they're needed for some other hemodynamic reasons, it's best to not focus on that, but focus primarily on the underlying condition. Now let's talk about the atrial fibrillation. So this is an atrial fibrillation, atrial flutter update. So as you all know, in 2020, the Canadian Cardiovascular Society, CCS, put out the most recent A.FIB flutter statement. And then in 2021, CAPE modified it slightly and has given us the most current guidelines we have on A.FIB flutter. So the 2021 guidelines are the most current, up-to-date A.FIB flutter guidelines. When we're dealing with stroke risk assessment for anyone who is in rapid A.FIB or flutter, we should be using the CHAD 65 score. We should not be using CHADS2. We should not be using CHADS2 VASC because those are outdated. Since 2014 to now, CHAD 65 is the current standard that's advised by the Canadian Cardiovascular Society and CAPE. What are the factors? Well, it's difficult to read in this, so I tried to summarize it for you. CHAD 65, so CHF is defined as having moderate or severe systolic dysfunction, hypertension. They say 2 or more separate events that were untriggered with a systolic pressure over 140 and a diastolic over 90, but you're not going to know that. In our clinical practice, all you're going to go on is, are they currently on an antihypertensive medication? That means they're chronically hypertensive. So then yeah, that gives you a point. If they have an age of 65 or more, or if diabetes, if they're currently on an anti-diabetic medication, insulin or an oral anti-hyperglycemic, then that gives them a point. And ischemic stroke or TIA, it's not a case where the person says, I think I may have had a TIA or I think I may have had a stroke, I'm not sure. It's something where they've actually been formally diagnosed by a neurologist, where they've actually had to go and get a CT angio, head and neck. They had focal neurologic deficits. They've been followed up in the stroke prevention clinic. This is an actual formal diagnosis that they have on their medical chart. If any of these criteria is positive, then that gives them a point. Now, As you know, all dysrhythmias can either be primary or secondary, like we talked about earlier with wide complex tachycardias. With A.FIB, A.FIB can be secondary to any strain to the heart. So whether it be sepsis, ischemia, PE, thyroid storm, toxidromes, etc. How do you differentiate a primary from a secondary A.FIB? Well, primary A.FIBs tend to be sudden onset, sudden change. I was feeling fine, and then I suddenly started to feel palpitations. Whereas secondary A.FIB, so the A.FIB is secondary to some other underlying disease, they're gradual onset. If you have a patient who has chronic A.FIB, and so their heart rate's normally in the 80s or 90s or whatever, and now they're suddenly showing up with rapid heart rate, that's not a primary A.FIB issue. That A.FIB heart rate, that rapid A.FIB is because of a secondary cause from an underlying disease like a thyroid storm, sepsis, or something else. And other clues that can clue you in that this A.FIB is secondary to some other issue is if they have abnormal vitals, if they have P risk factors, a fever, tachypnea, or some other reason to believe that their A.FIB is triggered by something else. If they have secondary A.FIB, you have to anticoagulate them for stroke prevention, and we have to focus on the underlying medical cause. Rate controlling them when it's compensatory A.FIB is not going to be beneficial to them. It'll often reduce their cardiac output and worsen their condition. Rhythm control, you can try, but it'll often be ineffective. And then there's the potential harm of giving an antidysrhythmic to a patient that really has an underlying sepsis or other issue. So you can try it, but it's often ineffective until that underlying condition has been managed. If the patient has unstable A.FIB that's defined as hypotension, so systolic pressure less than 90, altered mental status or shock, or they have to be in profound CHF, so they're hypoxia with oxygen dependence, or they're in significant dyspnea. This is not, I'm feeling kind of short of breath. No, they actually have to be unstable, hypoxic and severe dyspnea, or they have reasons to suspect ACS. They have severe crushing chest pain with significant ECG changes. You're going to get ST depression when you have a patient in rapid A.FIB as just as a demand ischemia change, but significant ECG changes, more than 2 millimeters in leads, with severe crushing chest pain, then you're going to be worried about acute coronary syndrome. This is considered unstable A.FIB. It's not the patient who says, I have a bit of chest pain, but it's chest pain, or I can feel my palpitations. That's not unstable. Unstable is rare. Unless they have secondary A.FIB or that they're in A.FIB with WPW, it's rare to be an unstable A.FIB. And if they are an unstable A.FIB, you must electrically cardiovert these patients immediately, regardless of timeline. If you have a patient, for example, in this is A.FIB with WPW, you cardiovert them. As we mentioned earlier, you do not give them an AV nodal blocker. Now, if they have stable primary A.FIB, this is all unchanged from decades old A.FIB guidelines. If they've been anticoagulated for 3 weeks or more, it's safe to cardiovert them. If they've had a negative TEE recently, it's safe to cardiovert them. You're never going to get that latter point, but just you're looking for anticoagulation for 3 weeks or more, you can cardiovert them. How do you know they've been anticoagulated adequately for 3 weeks or more? If they're on a DOAC, you're not going to really know other than on history. You just have to ask them that you've been compliant and then go over the risks and benefits of them being honest about it. As well, if they're on warfarin, you do an INR that day and you look for any recent INR values to make sure that they've always been above 2 and that they haven't had any recent dose changes to their warfarin because of inadequate anticoagulation. If the patient has a mechanical valve, mitral stenosis, or has ever had a previous documented TIA or stroke, you cannot cardiovert these patients. You should be rate controlling them and anticoagulating them and referring them to the stroke prevention, to the A.FIB clinic. So again, valvular disease or stroke or TIA, you should not be trying to cardiovert them. You should be sending them to the A.FIB clinic with rate control and anticoagulation. What's new, at least for me, and I hadn't incorporated this into my practice, was the timeline for cardioversion is if it's less than 12 hours in stable A.FIB, you can cardiovert them. If it's more than 48 hours, you rate control and oral anticoagulant. That's all the same as before. What's new to me, and I hope is helpful for you guys as well, is if you're in the window of 12 to 48 hours after onset of the rapid A.FIB flutter, you have to then use their CHAD65 score. If their CHAD65 score is 0 or 1, you can cardiovert. But if their CHAD65 score is 2 or more, you do not cardiovert, and you simply give them an anticoagulant, you rate control them, and you send them home. And you have them follow up in the A.FIB clinic. So again, the less than 12 hours, you cardiovert. More than 48 hours, you do not. But between 12 to 48 hours, you use the CHAD65 score. CHAD65 score of 0 or 1, you can cardiovert. CHAD65 score of 2 or more, you rate control and anticoagulate only. You do not cardiovert these patients. That's a deviation from the guidelines prior to 2020. For cardioversion, you, of course, use electricity. We always start with 200 joules and just go to the max. You can either do AP position or anterior lateral position of the pads. It really doesn't matter. A lot of studies have been done on this, and some show one way is better, some show the other, but honestly, there's no real clear decisive winner. So I always just use one method and I try 2 shocks in that method. And if it's not successful, I change the pad position, try a 3rd shock. If I've failed after 3 attempts, I'm sending them to cardiology anyway. The alternative to electricity is procainamide. That is the anti-dysrhythmic of choice, as opposed to amiodarone or other dysrhythmics. And procainamide is the chemical cardioversion agent of choice. You should avoid it though if the patient is hypotensive, of course, because they're unstable and you're giving them electricity at that point. Or if they have a long QT, then you should be using electrical cardioversion. Now, anticoagulation agents, DOACs are preferred over warfarin because they're more stable and they're more convenient. There haven't been a lot of head-to-head comparisons comparing DOAC agents, except for the last 2 months. 2 papers came out showing that apixaban is actually better than rivaroxaban in terms of bleeding risk. It's preferable over rivaroxaban on bleeding risk, but they're both small studies and they haven't. So now an RCT is now being done comparing apixaban to rivaroxaban. And that won't be completed for another several years. They're still enrolling patients through the 2023. So at this point, it really doesn't matter which DOAC you use, although I tend to use apixaban at this point anyway. DOAC contraindications, so you should not use DOACs if you have a patient who's pregnant or breastfeeding, they have a GFR less than 30, if they have any valvular disease, so mechanical valve or severe stenosis, if they're on an anti-epileptic, or if they're already on warfarin and they have a stable therapeutic INR, there's no need to change it. If they have any of these contraindications to a DOAC and you're starting them on warfarin, for example, you have a valvular, like a valve dysfunction patient, or you have a patient with renal dysfunction, you're starting them on warfarin, start them on 5 milligrams once a day. Unless they're really frail and elderly, you start them at 2 milligrams, and then you arrange for rapid INR check within the next 3 to 4 days, just to make sure that you've reached therapeutic INR. We used to say that we bridge with the low molecular weight heparin shots but we don't do that anymore. Now you don't need to bridge them. What's new to me is the anticoagulation timing. Now, post-cardioversion, the risk of cardioembolic events is high in the first 1 month post-cardioversion, but it's highest in the first few days post-cardioversion. So in the first few days post-cardioversion, up to the first full month, there's a risk of cardioembolic events. So we should not be deferring the starting of an anticoagulant to their family doctor. We should be starting them in the emergency department or urgent care. If a patient is obviously still in A.FIB, then you have to be oral anticoagulating them indefinitely and have them follow up in the A.FIB clinic. If they're being cardioverted back into sinus rhythm, either you cardioverted them back to sinus rhythm or they converted themselves spontaneously, either way, it was documented A.FIB flutter that went back into sinus rhythm. You then use their CHAD65 score to determine the anticoagulation timing. If they have a CHAD65 score of 0, you can consider 4 weeks of anticoagulation to help get them through that high risk period post-cardioversion. And if they have a CHAD65 score of 1 or more, then you do long-term oral anticoagulation. This CHAD65 score of 0, 4 weeks anticoagulation is based on weak evidence, but it is the current recommendation from the Canadian Cardiovascular Society, which is what we are judged against for our standard of care. So stroke prevention in A.FIB patients. If you have a prosthetic or moderate severe mitral stenosis, you're going to give them warfarin, not a DOAC. If you have a CHAD65 score of 0 and no history of coronary artery disease, after you cardiovert them, you're going to consider 4 weeks of an oral anticoagulant. And the reason we say consider 4 weeks of oral anticoagulant is because it's based on weak evidence. And so it would be a patient discussion with the patient, because their risk of having a stroke is extremely low. If this is their first event, they have a CHAD65 score of 0 and they have no coronary artery disease, their risk of developing a stroke is very low, but their risk of also bleeding is very low from being on an oral anticoagulant for only 4 weeks. So you have that discussion, but the current recommendations are 4 weeks of oral anticoagulant for a CHAD65 score of 0 with no coronary artery disease. If you have a CHAD65 score of 0 with stable coronary artery disease after the 4-week period of oral anticoagulant, then they should be on aspirin once a day thereafter. If they have a CHAD65 score of 1 or more with stable coronary artery disease, you can discontinue their aspirin and they should start an oral anticoagulant. So again, you have a patient with A.FIB who you've either cardioverted or not. If they have a CHAD65 score of 1 or more with stable coronary artery disease, they should be on an oral anticoagulant. We do not continue them on aspirin anymore. If they have a CHAD65 score of 1 or more and what they call unstable coronary artery disease. I'm not talking about an unstable angina. I'm just saying if the patient has had a PCI in less than 1 year ago, these patients are typically on dual antiplatelet therapy. Your treatment then is to discontinue the aspirin, continue the other antiplatelet, and start them on an oral anticoagulant. So CHAD65 score 1 or more who have had a PCI within a year, they're going to be on antiplatelet agent, not aspirin, and you start them on an oral anticoagulant. When you rate control patients, your target is less than 100 resting or less than 110 walking. If they're already on a beta blocker or a calcium channel blocker, you stay within that category of agents. If they aren't already on one and you have to choose, then you check to see if they've had any previous echoes. If they have an ejection fraction less than 40%, beta blockers are preferred according to the Canadian Cardiovascular Society. And the agents of choice are, of course, metoprolol or diltiazem. Metoprolol, you give them 2.5 to 5 IV. And as soon as you get them rate controlled, you give them PO as well. And then you discharge them with a prescription for metoprolol. If they're on diltiazem, same thing. You give them IV until you get them rate controlled and then give them PO right on top of it so that they have sustained rate control, and then discharge them with a prescription and follow-up. Follow-up would be at the anticoagulation clinic if you're giving them warfarin, in the A.FIB clinic for almost all of them, and their family doctor as well. Once they go to the A.FIB clinic, they are either, they're going to be assessed by cardiology for whether or not they need a pill in pocket, do they need to be on antidysrhythmics. If they've been anticoagulated for 3 weeks or more, then they will cardiovert them back into sinus rhythm. And then they will also determine whether or not this patient needs to be on antidysrhythmics or do they need an ablation. These are all things that we don't need to worry about, but it's good to know what the patient is going to expect, because the patient will ask us what they're going to do at the A.FIB clinic. So let's go over some cases. Case 1, if you have a 63-year-old female with a history of high blood pressure and stable coronary artery disease who presents with 15 hours of palpitations, and she knows that the timeline is good because it was a sudden onset 15 hours ago, I suddenly felt palpitations. Her home meds are amlodipine and aspirin. She's found to be in rapid A.FIB with stable vitals. She's not unstable. So your treatment is you calculate her CHAD65 score. CHAD65 score is 1 for her hypertension. Her onset was 12 to 48 hours ago. So then it is safe to cardiovert her, either electrically or with procainamide. Most of us would go to electricity. And then because she has a CHAD65 score of 1, she needs to be on an oral anticoagulant long-term, so you start her on a DOAC. And she no longer needs to be on aspirin according to the newest Canadian Cardiovascular Society guidelines if you're starting her on a DOAC long-term. One of the features I would like to mention is that you should do a HAS-BLED score, and you should have an informed patient conversation about the DOAC because of the implications of being on anticoagulation and the risk of the bleeding from that. So if this patient is a falls risk or has a high HAS-BLED score, then this does not apply. Case 2, a 50-year-old male has a history of stable coronary artery disease and hypothyroidism. They're only on Synthroid and they present in stable A.FIB for less than 48 hours. So you calculate their CHAD65 score. CHAD65 score is 0. Their onset was less than 48 hours ago. So you cardiovert them. And then you send them home with 4 weeks of an oral anticoagulant. And then after their 4 weeks are done, then you can start them on an 81 milligrams of aspirin thereafter for their stable coronary artery disease. Case 3, if you have a 70-year-old female with hypertension, diabetes, who's on amlodipine and metformin only, and she presents in stable A.FIB that started 24 hours ago, you calculate her CHAD65 score. CHAD65 is 3. Her duration is 12 to 48 hours. In this case, it was 24 hours ago. If you have a CHAD65 score of 3 with a duration between 12 to 48 hours, we cannot cardiovert these patients. We must rate control and start her on a DOAC and then refer her to the A.FIB clinic. Once she's been anticoagulated sufficiently for more than 3 weeks, then she can be safely cardioverted back into sinus rhythm. We do not try to rhythm control this patient in urgent care or emerge. Now, the last topic we're going to talk about is ECGs in syncope. Now, whenever you manage this patient with syncope, of course, we use the Canadian syncope rule, and we use our clinical gestalt on what's caused their syncope, and you have to differentiate syncope from seizure and so forth. But when you have a patient with syncope, you must get an ECG. And what are we looking for on this ECG? So I always have trouble remembering all the different criteria. So when one acronym that I found, or mnemonic that I found useful, was WOBBLER. WOBBLER is WPW, obstruction, Brugada, fascicular blocks, LVH, epsilon waves, or repolarization abnormality. So we'll go through each of them. So first, WPW, as you know, a PR interval less than 120 and delta waves if they have signs of obstruction. And when I say obstruction, is AV nodal block of second degree type 2 or third degree AV block with syncope, they need a pacemaker. If you have signs of a PE, which on ECG are, T wave inversions and ST depression in 2-3 AVF, right bundle branch block, tachycardia, right axis deviation. If you have signs of cardiac tamponade, like low voltage, electrical alternans, tachycardia. So you look for, these are the signs you look for on the ECG that there might be an obstructive cause to this syncope. You also, then next thing is on WOBBLER is Brugada syndrome. So that coved ST elevation in leads 1 to 3, you only need it in 2 of the leads of leads 1 to 3, V1 to 3. You're looking for that coved ST elevation. If you have a bi or trifascicular block, in this case, for example, we have a right bundle branch block with a left anterior fascicular block. If you have a bi or trifascicular block with syncope, then this patient needs a pacemaker. You need to send them to hospital. If you have LVH, it can be with syncope. You have to think, could this be aortic stenosis? Or in this case, where you have dagger Q waves with the LVH, you could think of hypertrophic cardiomyopathy. So this patient needs to be sent to cardiology. If you see an epsilon wave in V1 to 3, that it's that little blip just after the QRS, then that's a sign of arrhythmogenic right ventricular dysplasia. So epsilon waves, arrhythmogenic right ventricular dysplasia, this patient needs to be sent to cardiology if they're coming in with syncope, because you need to rule that out. Or if they have a repolarization abnormality, so if a QT that's abnormally long or short, then that could be their cause of syncope. So in summary, section 1, we talked about dysrhythmia management. If you have a regular narrow complex tachycardia, it's either orthodromic AVRT or ABNRT. Either way, you treat them with an AV nodal blocker, adenosine, amiodarone, beta blocker, calcium channel blocker, or digoxin. If you have an irregular narrow complex tachycardia, it's rapid A.FIB flutter, which we'll talk about next. If you have regular wide complex tachycardia, it's either antidromic AVRT or VTAC, but we should always treat it as VTAC with either procainamide or electrical cardioversion. And if it's irregular wide complex tachycardias, it's either VFib, which is straightforward defibrillation ACLS, or it's electrical cardioversion. You do not give these patients AV nodal blockers. In terms of A.FIB guidelines, rapid A.FIB flutter guidelines, we should not cardiovert patients if they've had a previous stroke or TIA that's documented, if they have known a prosthetic valve or rheumatic mitral stenosis. And we do not cardiovert patients if they're stable and they're within the 12 to 48 hour period with a CHAD 65 score of 2 or more. We do not cardiovert those patients. We rate control and oral anticoagulate only, and then refer them on to the A.FIB clinic. If any cardioversion occurred either spontaneously or iatrogenically, you need to anticoagulate these patients. If you have a CHAD 65 score of 0 and you've been cardioverted, you need to give them 4 weeks of oral anticoagulation. If they have a CHAD 65 score of 1 or more, then they need long-term oral anticoagulation. And lastly, the syncope ECG, look for the signs of WOBBLER, WPW, obstruction, Brugada, fascicular blocks, LVH, epsilon waves, or repolarization abnormalities. Thank you for your time.